Okay, so welcome to today's session on our MDC style question walkthrough. We are presented with a 72-year-old man with history of memory loss, and his brain CT scan is shown, below. We are asked to make a diagnosis based on this, history and the image. The options are dementia, epidural hematoma, chronic subdural hematoma, subarachnoid hemorrhage, and brain abscess. So this question, the stem is very small. The stem of the question is very short, and making a very accurate diagnosis based on just this short information is probably not the best. And so that's why we've been giving an image to help us in making that diagnosis. We could drive differentials from just this information without the image, but to make the most likely diagnosis, which is what the question is asking for, we need to be able to read this image in addition to the history, the small history that we've been given in the question. So it means that you need to have an idea of what this question is about, and also some idea on how to read a brain CT scan. So we are going to have a brief overview of the topic around which this question was taken, and we are going to refresh our knowledge on it and come back to try and discuss this question in details. So this question was taken somewhere around this topic of intracranial hemorrhages and bleeds, and so we are going to discuss that, and specifically we are talking about subdural hematoma. So subdural hematoma is it refers to a bleed or hemorrhage into the intracranial subdural space, and this space is what lies between the dural matter and the arachnoid matter. It typically arises from bleeding of a bridging veins. So the bridging veins are veins that connect the superficial cerebral veins to that of the meningeal veins and the subdural venous sinuses. So we have these tiny veins arising from the surface of the cerebrum, and they cross the space between the brain itself, the cerebrum, the superficial cerebral vessels, and they traverse the space all the way to the dura and the meningeal vessels. So that's where these veins are, and these veins, when they rupture, then you can have a subdural hematoma. So they're bridging veins. So when here, subdural hematoma, bridging veins, right? So how do we classify subdural hematoma? Subdural hematoma is classified based on the length of time between the onset of the symptoms and the inciting event. So whatever event incited the bleed, the time from which that event occurred to the time when symptoms begin to occur, that's what we use in classifying the subdural hematoma. So SDH can now be classified as acute. That is, the onset of the symptoms is within 3 days of the inciting event. So that is within 72 hours. We have subacute SDH, which is symptom occurring within 4 days to less than 3 weeks of the onset of the inciting event. And you have chronic SDH, which typically present with symptoms after 3 weeks of the onset of the inciting event. So typically they are more, SDH are more common in the male than in females, and some theories are proposed because males tend to indulge in activities that might increase or predispose them to having these bleeds. So for instance, alcohol consumption is more common in males, and alcohol consumption can increase your risk of bleeding and can also cause brain atrophy, which is also one of the risk factors for subdural hematoma. Then age-related brain loss tends to be more pronounced or marked in the male sex than the female counterparts. So that's also some of the things that some of the reasons why AMIs and SDH might be common in males. And the acute subtype of SDH typically occurs in younger patients because that is mostly traumatic, and young patients are involved in a lot of adventurous things, and they are more likely to involve in some kind of a traumatic event. And so those typically occur in that. But the chronic type tend to occur in elderly people, and especially in people or patients in the extreme of ages, infants and toddlers, and very extreme ages like the elderly patients. Right. So now let's talk about some of the etiological factors for SDH. For the acute SDH, it mostly occurs following trauma, so some form of a high energy impact trauma, especially in vehicular accidents. So RTAs in our setting is very common, one of the common causes of acute SDH. We also have non-accidental causes of it's traumatic, but it's not accidental. These are traumatic, non-accidental traumas. So like shaking baby syndrome, this is a classic sign of child abuse in children, where the caregiver or a parent is violently shaking an infant, and that leads to a tear of these vessels. The shaking of the baby causes inertia and relative movement of the brain tissue, and causes shearing effect and tearing of these bridging veins, and leads to bleeding in these children. And it's a classic sign. When you see that, it's a classic indication that there might be some form of a child abuse going on there. Then you have acceleration deceleration, which is kind of similar to what is occurring in the shaking baby syndrome, where you have this baby is violently you're shaking the baby violently, and you have this acceleration deceleration. So that's what's happening. Acceleration deceleration injury, you have your coup and contra-coup injuries. An example of that is an example of a acceleration deceleration injury. So you're in a car which is rapidly accelerating and suddenly hits, crashes into something. You have this sudden deceleration, and there's this shearing effect where you have relative movement of the brain tissue. This inertia, force is causing a relative movement of the brain tissue against different parts, and that can cause a shearing or tearing of the bridging vessels and leads to bleeding. Right. Now let's talk about the chronic type of SDH. Now the chronic type of SDH, it could be traumatic or non-traumatic. So the traumatic causes, in adults, typically it follows, a very mild trauma, and this is typically occurring in patients, the elderly patients. So a very mild trauma. Some of them, they don't even remember that there was any prior history of trauma, because the trauma that they had probably just bumped their head into something very light, and they can have the bleed. We'll talk about why that is the case. Then in infants, as you mentioned, not accidental trauma is also in shaking baby syndrome. You can have that. Birth traumas can also cause that. Difficult birth occurring with traumatic delivery. These babies can have subdural hematoma, which could be picked up weeks later after the onset of the event. Then you have the non-traumatic chronic causes of chronic SDH, also typically occurring in adult and elderly patients. And this is a classic type that you find, occurring in elderly patients, usually non-traumatic, no history of trauma, and they bleed. And this is because in the elderly patient, you have brain atrophy, and the brain atrophy causes the brain volume to reduces. And once you now have the brain volume reduces, it increases the space, the subdural space. So the subdural space now increases, and it means that the bridging veins, which we said traverse the subdural space, it travels from the superficial, vessels, cerebral vessels, and traverses the subdural space all the way to the dural vessels. That space now widens, and so it means that the bridging vessels have to travel a long distance, and they get thin, and long, and that increases their risk of tearing up. And so you have that, increasing the risks of a bleed. And so patients with cerebral atrophy, which is a very elderly patient, advanced age, where you have brain atrophy or loss of brain tissue because of advanced age. People who abuse alcohol also tend to have some kind of atrophy occurring in their brain. And other neurodegenerative conditions like Alzheimer's and vascular dementia and HIV dementia, these are all conditions that can cause brain atrophy and reduce of the brain volume. And so these are some of the things, non-traumatic causes of chronic SDH in the adult. Now for infants, there are also at increases of this, especially those who have developed meningitis, for instance, can also cause rupturing of these vessels, usually non-traumatic. Then in both age group, whether infants or adults, bleeding tendencies, those who have bleeding tendencies, like they are on some kind of anticoagulants, these are predispose the person to having these bleeds occurring in the subdural space. All right, so now let's switch gears and talk about the clinical features of SDH. We'll start with the acute type. Now, so the acute type of SDH, the clinical features typically, whether it's acute or subacute or chronic, the features typically depends on the size of the blood, the size of the hematoma and the location of that hematoma, and the length of time since the inciting event. So, these symptoms, these are some of the things, the features that might influence the symptoms that the patient might present with. So the size of the hematoma, where the blood is collected, the site, so where is it located, the location, and then the size, how big is the blood, how massive is the bleeding. But because it's a venous bleed, it usually tends to be insidious. but it can present with rapidly progressive symptoms, especially in the acute case where mostly is traumatic. Okay, so the acute SDH type, the symptoms typically present immediately after the onset of the trauma or the inciting event, which is in most cases traumatic. Some people might have this lucid interval, which typically is seen in people with epidural hematoma, which is another entity on its own, which we are going to talk about in another time. But they might also have the lucid interval. Now, in the lucid interval, typically this is what happens. A patient is involved in some kind of a traumatic event, loses consciousness, regain consciousness a few minutes or an hour later, and then seems to be fine. That's a lucid interval. They seem lucid. There's regain of lucidity. They are conscious within that period of time and seems to be well. And then few hours later, level of consciousness just drops and dips, and then the patient never wakes up. This is what typically happens. You see in epidural hematoma, but can also occur in subdural hematoma, especially the acute type. So the symptom onset typically immediately after the traumatic event. They might have the lucid interval in a very small amount of patients, percentage of patients, and the progression of symptoms is usually very rapid. So there's a rapid progression of symptoms, which can lead to cerebral herniations and subsequent death. So you have your impaired level of consciousness, confusion, rapid deterioration to coma. Then you might also have focal neurological signs, so like contralateral hemiparesis, which is typically your upper motor neuron lesion signs, which is contralateral hemiparesis with upper motor neuron lesion signs, telling you that this lesion is high up in the CNS. And in some few cases, you might have what is called the Conahan syndrome, where you have ipsilateral hemiparesis. This is actually a false lateralizing sign, and it's because lesion that is occurring on the right side. So if you have a hematoma collected on the right side, we're expecting the weakness to be on the left side of the body. That is the contralateral hemiparesis. That's the typical presentation. Now, we might in some cases have ipsilateral hemiparesis. So you have a blood collection on the right side and you have weakness of the body also on the right side. And this will create the impression that the lesion is on the left side of the brain, but in actual fact, the lesion is on the right side, the same side of the weakness of the body. And this is false lateralizing sign. And this is because of what we call the Conahan syndrome. So Conahan syndrome is, is because of ankle herniation. So herniation of the ankles, which is a part of the temporal lobe, which is herniating and compressing on the cerebral peduncle. So when you have this corneal ankle herniation, there's a paradoxical weakness on the side. So it's paradoxical. You have lesion on the left side of the right side of the brain. We are expecting weakness on the left side of the body, but then you are seeing weakness on the right side of the body. So it's paradoxical, and it's a false lateralizing sign. And this is because of herniation of the ankle herniation. So this you might also see in patients with acute SDH. But typically what you see is contralateral hemiparesis because of impingement or the impact of the hematoma on the contralateral side, lateral side of the brain. Then you can have cranial nerve palsies manifesting with double vision, so diplopia, blurred vision. You have unequal people, so anisocoria. Then you can also have anosmia because of the olfactory lobe, olfactory nerve involvement. Then you have symptoms of increased intracranial pressure, so headache, vomiting. Then you have your Cushing's triad. So the Cushing triad is from the Cushing reflex, so where your body tries to increase the blood pressure in order to push more blood to the brain. When you have increase in the cranial pressure, blood supply to the brain reduces because the pressure with which blood is supposed to move to the brain we have to increase in order to allow for blood circulation to the brain. Okay, so in increase in the cranial pressure, what is happening is that you have an increased blood pressure, the heart rate reduces, the bradycardia, and then you have an irregular breathing pattern, and that's what is called a Cushing's triad. Those three things: increased blood pressure, bradycardia, that's a slow heart rate, and then irregular breathing pattern. Okay, and this is occurring as an evidence of an increase in intracranial pressure. So these are all things that you can find in patients presenting with acute SDH. Now you see that these symptoms are the same as you find in somebody with epidural hematoma. So typically, clinically, you are not able to distinguish between these two clinical entities, and so you have to do some form of neuroimaging, and that probably might help you to distinguish between an acute SDH and an epidural hematoma. Now, chronic subdural hematoma, the symptoms are a little bit more insidious, and they tend to present 3 weeks, 21 days after the inciting event, and tend to progress more gradually. I've kind of skipped over the subacute SDH because it's a combination of the acute. The symptoms are more of a combination of the acute and the chronic type, and so we're going to discuss the chronic, and so you combine that of the acute and the chronic to get your symptoms for the subacute. But typically that one, as you said, the symptoms present within 4 days, so about 20 days after the inciting event, that is a subacute. And then it could be acute or insidious in onset, but may progress rapidly, especially when you have a rebleed occurring. But typically the clinical features is a combination, or it's a mixture of that of the chronic SDH and that of the acute SDH. So let's talk about the clinical features of chronic SDH. You have altered mental state that can progress to coma, and is characterized by your confusion, delirium, drowsiness. Then some patients in some instances may present with headaches. This is especially in the young patients who might have these recurrent headaches. It's not very common in the elderly, because in the elderly there's brain atrophy and there's nerve space in the brain, so the person can continue to bleed and not have evidence of increase in the cranial pressure, and therefore they won't have this headache. So typically, the chronic SDA that present with headaches is a type that commonly occurs in a young patient. Then you have cognitive deficits, which is one of the classic features of chronic SDH. You have impaired memory with a typical symptoms of dementia, and it's one of the common causes of reversible dementia. Okay, you might also have other clinical features like contralateral hemiparesis, like your neurological devices, like contralateral hemiparesis that can progress hemiplegia, and you can also have other clinical neurological features like incontinence as well in the cases of chronic SDH. Okay, now how do you diagnose SDH, whether it's chronic or acute? Your history and examination, of course, is important, but definite diagnosis will have to be done using some form of neuroimaging, and the recommended neuroimaging modality is a CT scan without contrast. Now, you don't want to use it with contrast because contrast is hyperdense, blood in the brain is hyperdense in an acute phase. That could create some confusion, so you don't want to add that kind of contrast that will cause confusion, and contrast in this case is useless, so it's usually without contrast. So CT scan without contrast. And the characteristic features that you find on these CT scan images is a crescent shape lesion, concave or crescent shape sharply demarcated lesion, and this lesion can cross cranial suture lines. These are very important things you should take notice of, because there's another lesion, brain intracranial bleed, that does not cross suture lines. So these are things that they want you to know during the exams, especially during the viva station. They ask you to describe the features so these features, these kind of lesions in SDH, that's subdural hematoma, they don't cross the midline, but they cross suture lines. So they can cross the suture lines, but they cannot cross the midline. Now, why are they able to cross suture lines? We'll talk about these differences, especially when we're talking about epidural hematoma, which is a contrast of this, where you have epidural hematoma can cross the midline but cannot cross suture lines. Suture lines, because they can cross suture lines because the bleeding is occurring below the dura. The dura is tightly adhered to the sutures. The sutures is where you have these the skull bones, where the joints of the skull bones, and you have the dura sharply adhered to these suture joints or suture lines. But in subdural hematoma, the bleeding is occurring below the dura. So if it's occurring below the dura, there's free space there, and it can cross along the suture lines. But in epidural hematoma, which is the opposite of that, the bleeding is occurring on top of the dura, and because the dura is attached, at the top part to the suture lines, the blood cannot cross over those suture lines. But it can't cross, subdural hematoma cannot cross the midline, because the midline is made of the cerebral falls, which is made of the meninges. And this is like a bridge. You are under the bridge. You can't cross through those bridge pillars. It's a pillar. But if you're on top of the bridge, you can ride along the bridge. So that's what's happening. So in epidural hematoma, they can cross above, they can cross the midline in epidural hematoma, but in subdural hematoma, they can't cross below that midline. But they can cross suture lines. So those are the classic features: the shape, the fact that they can cross suture lines, but they can't cross midlines. So now let's talk about, the radial density of these lesions based on the chronicity or the type of SDH. So the for the radial density of these lesions for acute SDH, they are typically hyperdense lesion, which you see. Then for subacute, you have isodense lesions, isodense. Then you have chronic, hyperdense. Hyper means increases, higher density than the surrounding tissue. Isodense means iso, the same, isodense, so the same density as the surrounding tissue. Then you have hypodense. Hypo means low, so low density as the surrounding tissue. Then you have acute on chronic, so it's a mixture of hyperdensity and hypodensity. That's what you are seeing, and this classically you see that on the CT scan without contrast. Now let's take a look at these images. Now this image, you can clearly see this, this crescent shape hyperdense lesion, isn't it? Crescent shape, hyperdense. It's hyperdense, it's white, it's whiter than the rest of the brain, and there seems to be something like that. The brain looks curved up there and is pushing things on that side, it's pushing things to this side. So if you look at the midline, it is this curve thing like that. So it means that there is some form of a midline shift. So there's a midline shift. So there's this is a classic appearance of an acute SDH, with a midline shift. And even when you look at this area here shaded green, it looks a little bit smoother than the rest of the brain. So there's effacement, sulci effacement, and this is cerebral edema. So this is a perilesional edema. Then you can't even find the lateral, the lateral ventricle on the left side of the brain here, where the side of the lesion is, but you can find it, the posterior horn of the right lateral ventricle, is over here, is very dilated. Means that we are squishing things, you are pushing things, pushing it to the right side because there's pressure building up on the left side here. That's what's happening. So this is a classic appearance of an acute SDH, with a midline shift, evidence of increase in the cranial pressure, dilated obliteration of the lateral ventricles, midline shift, dilated contralateral ventricles. These are all evidence of increase in intracranial pressure. Right, this is another image, again showing you a hyperdense crescent shape lesion there. Crescent shape lesion, hyperdense, whiter than the rest of the brain. And interesting thing that's going on here, outside the scalp, outside the cranium, but within the scalp. So this is the skin of the scalp there, but there's this other collection here. This is outside the scalp, outside the cranium, but there's this other hyperdense collection here. This is an extracranial, hematoma that is also collecting within the scalp here. And then you have, this intracranial bleed, so this is another example of an acute SDH. Okay, and then you have this, quite an interesting image. You have, classically you have this your crescent shape structure here, and as I said, it's crossing midline, so it's crossing suture line, sorry. So there's supposed to be a suture somewhere around here. There's a suture joint around somewhere here, but you can see that this thing is crossing over there. It's crossed beyond those suture lines. So this is a classic example of a subdural hematoma, and it's crossing, crescent shape crossing suture lines. But something interesting is going on here. The color of this crescent shape, lesion is a little different when you come right from here. So when you shape it right from here, it looks, this area looks a little whiter than this area, isn't it? So there is some kind of hyper, or accurately you can say is isodense, because the density looks more like that of the brain tissue. So some kind of isodensity going on here, but this looks a little bit more darker, so there's hypodensity. So there is hyperdense or isodense mixed with hypodense. So this is an acute on chronic SDH. Acute on chronic SDH. And you can see the patient is lying down supine, and so you can see that the dense blood, or the dense part of the the blood is going down, is settling down by density. Of course, denser one will settle down and the hypodense one will rise up. So that's what's happening here. So you have the hypodensity, which is occurring up, rising up, and then the hyperdensity, which is at the bottom. So this is an acute on chronic SDH. Okay, so how do we manage this patient? How do we manage patients with SDH? Whether it's acute or chronic or subacute. The management depends on whether the patient is symptomatic, or not. For people who are symptomatic, you always have to involve the neurosurgeon, and they will typically, will have to do some form of hematoma evacuation. You have to take out that blood because the patient is symptomatic, deteriorating, evidence of, intracranial herniation, ICP, increased ICP. These are all evidence for surgery. And for patients who are symptomatic, obviously, you need a neurosurgical consult for evacuation of the hematoma. But, aside the surgical consult, you can do some, empiric medical treatment to relieve, that intracranial ICP, increased ICP. Okay? And so neuroprotective measures. So, you're trying to help, nursing the bed, the person putting the nursing them in a bed where the head is slightly elevated, hyperventilating them, giving them some monitor or some diuretic to relieve the brain pressure and all of that. These are all some other measures that can be done, but definitely that hematoma have to be evacuated. But for those who are asymptomatic, for asymptomatic type, whether it's acute or subacute or chronic, still you need to consult a neurosurgeon, and the neurosurgeon will now decide whether there's going to be surgical or conservative management. Now, for surgical management for such patient asymptomatic SDH, typically when you have your hematoma size greater than 10 millimeters, for instance, that's an indication for surgical evacuation. If there's a midline shift of more than 5 millimeters, if there's signs of intracerebral or cerebral herniation, or there's signs of increased intracranial pressure, so if the intracranial pressure is greater than 20 millimeters of mercury, that is some indications for surgical management. And obviously, if you've tried the conservative management and it has failed, you have to abandon that and do your surgical management. So obviously, the opposite of this, are things that will let you want to manage these patients, conservatively. So if the hematoma is less than 10 millimeters, there's a midline shift is less than 5 millimeters, there's no evidence of intracerebral herniation, pupillary reflexes are fine, no increase of intracranial pressure, so you try to manage them conservatively, observe. But these are people who are supposed to be managed under neurosurgical consult, ICU monitoring, continuous monitoring, and surgical intervention when the need arises. Right, so hopefully that was enough information. So let's go back to our question and see if we'll be able to answer it. So the question said a 72-year-old man, so 72-year-old, that's typical an elderly person, you have memory loss, and we've been given our brain CT scan, and we've been asked to make a diagnosis. So information, as I said initially, is very scanty here. The only thing you have is an elderly patient, memory loss, CT scan. So we need to be able to read a CT scan. Let's try and see if we can read this CT scan. We can see some hypodense lesion here, and it's crescent shape crossing the midline. And that is your classic description of what an SDH. Crescent shape, the shape, the color of that lesion now depends on the chronicity of the inciting event. And, but the fact that it's crescent shape, you see that is occurring within the subdural space. And this lesion looks, hypodense. It looks a little bit more darker than the rest of the brain, so it's hypodense. So telling us that this is a chronic lesion. So this is a chronic SDH, and we said it's one of the common causes of reversible dementia. So this patient, you can confuse that with Alzheimer's dementia. Is old, you can develop dementia. That's fine, but with the presence of this CT scan findings, it is more likely that this patient has a chronic subdural hematoma, which is one of the common causes of reversible dementia. So once you evacuate this hematoma, patient's memory loss will typically resolve. All right, so I hope that was helpful, and catch you again in the next session. Thank you.